that single lung transplantation has significant long-term survival disadvantages, and the question you come back to is why is there an advantage to double lung transplantation? And I think one of the elements is the issue of acute graft failure. Acute graft failure has declined in its incidence from a 20-25% range down to about a 10 or 15% range, I think in large part due to the use of the low potassium dextran solution. But it's clearly easier to manage acute graft failure in terms of ventilation and hemodynamic effects and the like in someone who has symmetric lungs, if you will, than in someone who has one hyperinflated lung that traps air and one relatively non-compliant edematous lung graft, say in an emphysema patient. There's also this argument of bronchiolitis obliterans and volume of lung being important, and just the idea you have more gas in the tank. If everyone's going to get bronchiolitis obliterans, you're going to be able to go farther, if you will, if you have more lung tissue around. But I think perhaps the key to it all is the idea that our chronic lung diseases, we're gaining more insight into really the pathogenesis of these chronic lung diseases, and that they're diseases of inflammation and possibly particularly emphysema or COPD, that is, diseases of autoimmunity. And that applies to both of these, and so that may have an impact in terms of the long-term survival. The bronchiolitis obliterans syndrome argument, patients seem to some extent be fated to develop bronchiolitis obliterans. Maybe not all patients, but clearly in the lavage, the presence of chemokine markers of patients long before they develop symptoms of bronchiolitis obliterans syndrome suggests that there are those patients that are going to develop the process whether we want them to or not. Pulmonary fibrosis patients, we used to think, of course, that there was some stimulus that caused chronic unremitting inflammation and fibrosis, but in fact, it's clear that there are repeated stimuli, one of which may be asymptomatic gastroesophageal reflux, and it's this repetitive injury over time that sets up an imbalance between the proliferative and fibrotic components of the inflammatory process that ultimately lead to pulmonary fibrosis. The important element there is that wherever that stimulus is that's causing the persistent fibrosis, the repeated stimuli that cause repetitive lung injury, that's still intact. We don't do anything to correct that with single lung transplantation in the native lung. And more significantly, I think there's this whole body of evidence emerging relating to the fact that alveolar type II epithelial cells in fact are antigen-presenting cells and probably serve as a very important interface between adaptive and innate immunity in the lung, dealing with the lung mucosal barrier, the alveolar type II epithelial cells processing antigen with MHC class II presentation to dendritic cells, and then have the capability to cause naive T cells to become both effector cells and to become T regulatory cells as well. So the alveolar type II epithelial cells can both elicit an immune response and shut down that immune response in a clonal fashion. And the premise here, or the supposition, is that in fact patients with emphysema have some disorder of this Treg formation and in fact have an autoimmune response against their native alveolar epithelial cells. So the patients with emphysema always ask, well, is that other lung, what about that? Is that going to do me any harm? And we say, no, it'll be fine. But in fact, it may in fact be hurting them in the long run. But what about donor availability? So this idea that, okay, if double lung transplantation really is better than single lung transplantation, aren't there times when we have a donor that can only provide one lung? And clearly the answer to that is yes, but I think the caveat there is not as often as perhaps we think. And certainly with an allocation scheme based on recipient acuity and the electronic notification process, so we can see CT images and look at blood gases and have a dynamic interaction with the organ procurement organizations to see if recruit maneuvers, for instance, will make this area that's called pneumonia go away because it's really relaxation atelectasis, that sort of thing, have improved the overall donor pool, if you will. And in fact, something that's currently just e-published but will be coming out later this year, the University of Pennsylvania group looked at risk factors for primary graft dysfunction in UNOS registry data from, I believe it was 1996 to 2002, 7,000 patients. They found that these were the risk factors for primary graft dysfunction: age greater than 45, head trauma as a cause of death, obesity in the recipient, female gender, urocolons flush, which I would hope for most of us is thrown out the window, elevated PA pressure, pulmonary fibrosis, and single lung transplantation, all as risk factors for acute graft dysfunction, underscoring the idea that in fact, PO2 perhaps and radiographic appearance perhaps may not be as important as we once thought. And in fact, when you look at the more recent registry data here, you can see again, not only that the number of single lung transplantation is diminishing in proportion to the number of double lung transplantation patients, but compared to 2000, we've had a 50% increase in the number of transplants that can be done. So we are finding more donors. There clearly still aren't enough donors, but there are more donors out there than we could appreciate before. So that I would say that to a large extent, if we want to do the best thing for our patients, that double lung transplantation should be our first procedure of choice. Now, to paraphrase Shakespeare from Julius Caesar, the evil that operations do remains, and the good is oft interred with their bones. And I'm not suggesting that we inter single lung transplantation. The good part of it is it's a good place to start. It's a good place to learn lung transplantation. It's a good place to learn the physiology of lung transplantation. It clearly was a way to learn a lot of things about the physiology of the chest wall and respiratory mechanics we wouldn't have known. And clearly, in early experience in all programs, I would say, the experience with single lung transplantation in terms of operative mortality and survival is better. But the evil, so to speak, is that the outcomes, the long-term survival of patients after single lung transplantation are clearly less. So that if one looks at pulmonary fibrosis, should you do a single lung transplant for that? Occasionally, probably in older patients or patients with normal pulmonary artery pressures. In patients with garden variety COPD, not the alpha-1 patients. Clearly older patients perhaps, or patients with a smoking history, those non-innocent people, if you will, politically incorrect types are ones that potentially you would think of as managing with single lung transplantation. I think in the current construct, alpha-1 antitrypsin deficiency should rarely be an indication for single lung transplantation. Sarcoidosis is a whole other disease that we're still figuring some things out about, but probably it's a very reasonable indication for single lung transplantation. And there are clearly some technical issues, some times when there are acute problems intraoperatively or prior to the operation that would suggest that single lung transplantation, just as Brian suggested, which is a quick, straightforward operation, is the way to go. But on balance, I think that single lung transplantation is on the wane, if you will, and that double lung transplantation should be the thing. Should be the thing that comes first to our mind in terms of how to do a transplant. Thanks very much.